morning for Western countries and good afternoon, Eastern countries, and good evening for those in Auckland and Australia. It's my pleasure to welcome you all to our first Wonka Working Party on Research webinar. This webinar is a collaboration between Family Medicine Academic Center under the Royal College of Family Physicians of Thailand, together with Wonka Working Party on Research. We have proposed this webinar, which will be a series of webinars through the year 2022 to 2023, in order to share experience and learn from the experience of family physicians around the world, how they are doing in providing care and what are the progress that they have made. In order to start this meeting, I would like to invite Professor Mehmet Akman, the current president of Wonka Working Party on Research. Professor Mehmet, the floor is yours.
Thank you very much, Mi. Warm greetings to my all colleagues from all over the world. It's my honor to address you in this first webinar of a webinar series as the chair of Wonka Working Party on Research. As we said, actually, I'm also very pleased. I mean, a few months ago, we were sitting an idea, and it became, with the help of all the colleagues, such a nice job at the end. So I would like to thank the Royal College of Family Physicians of Thailand for their support. So Wonka worldwide, I mean, for their technical support, and also for their all efforts and support to realize this webinar series. I just want to give a few information about how this will happen in the future as well. So this is a one-year process we are planning, and we would like to have teams. Actually, the first one is starting today with the core functions of primary care. So we will have 2 webinars on each team, and then in total it will be presented on each team. And secondly, we will go to the core value primary care, and then in the third team we will go the practice transformation, especially 19 period. And our approach will be a kind of a case-based approach. So there will be a case presented with a pre-prepared structured slides. Countries will approach according to their setting, how they handle this case. So in brief, this is the setting, and I mean, any wants to present in the next webinars, please don't hesitate to contact with us. Now, I would like to give the floor to Felicity Goodyear-Smith, the previous chair party on research, to present the case. And afterwards, we will hear how 4 countries today, 4 different countries will approach to this case. Please, Felicity.
Thank you very much, Mehmet. Lovely to see everybody. Lots of old faces and new people as well. So I'm very privileged to be able to be part of this webinar series that's being organised. I'm just going to share my screen. Here it is. So hopefully that is now visible. And I'm really just going to present this case. As Mehmet said, we're going to, these are similar to what we've done before, where we have 4 countries, 5 countries presenting on a particular template of slides so that we can compare each country. But in this series, we're actually using cases, and people are looking at this case and how they would look after this case in the context of their own country and their own primary care system. Sorry, there we go. So this is a case we're calling her May. She's 75 years old, and she was a bank officer. Her husband died 15 years ago, so she's now a widow, and she has 1 son who lives a long way away, and he has limited ability to come and visit her. But when he came last weekend, he was rather concerned about her condition. and her home was unkempt, and he was unaware of how much her severe arthritis had been affecting her ability to function independently. But she was also coughing and she appeared short of breath. And when he said, why didn't she ask for help? She said she didn't want to worry him. I'm sure we've all known patients like that. When asked, she admitted to having a cough for 5 days, and her breathing was getting worse despite using her inhalers. She didn't think she had an infection because she didn't have a fever, and therefore she didn't go to see the doctor. So her son Lee decided to seek help for her, and he booked her an appointment with her primary care physician for the next morning. So her history, she had a 20-year history of multiple medical problems. She had osteoporosis, she's had a hip replacement. She suffers from hypertension, type 2 diabetes, and COPD. And her vision's been getting worse over the last few months, and the pain in her feet means that sometimes she's just not able to do the housework. And she used to be a very heavy smoker, but she quit when she was 65. She doesn't drink much, very little alcohol, occasional wine on special occasions. Lives independently at home, not been visiting her primary care physician regularly because she can't drive anymore. Very hard to find someone to take her to a health centre. And she used to get on well with her previous primary care doctor who'd looked after her for over 10 years, but he's retired now. And she's been reluctant to repeat all her medical history to a new doctor. So she keeps taking her antihypertensive and anti-diabetic tablets, and she uses her inhalers for her shortness of breath, but her blood pressure and her diabetes are not being monitored. So the structure of this webinar is, so this is a case about a woman who has multi-morbid conditions, but she's presenting with both acute and chronic issues. And so we've got the family medical experts from these 4 countries, and they're going to discuss how they would manage her in their own primary care setting, as if they were the primary care physician looking after her. And they're going to look at the core primary care functions of comprehensiveness, continuity, coordination, and access. So that's the cases, and I'll pass it back to Bea, who will introduce our first speaker. Thank you very much.
Thank you very much, Professor Felicity. So we see a complex case with a acute problem, and we are going to learn how it's going to be approached by 4 invited speakers. So the first one will be Naoko Kobayashi, who is a family physician at Machinaga Clinic from Toyama City, Japan. And the second presenter will be Dr. Ravipon Jaran-Sawat, a young family physician who works in Nan Hospital in the north of Thailand. The third presenter will be Professor Bob Mash, the head of family medicine and primary care from Stellenbosch University, South Africa. And the last presenter will be Professor Tin Mew Han, a founder of Primary Care Research Unit in Myanmar from Myanmar GP Society. And we will also have a commentator. And during this for this webinar, we have Professor Chris Van Wiel, who is former president of WONCA, who will give us final thoughts after the presentation. So now I would like to invite Naoko. The floor is yours, Naoko.
Okay, thank you very much. And now let me share my slide to everybody. Okay, and thank you. Good evening, everyone. I appreciate you joining today. My name is Naoko Kobayashi, and I am family physician at the Toyama City Machinaga Clinic in Toyama, Japan. The purpose of my presentation today is to inform you of the current state of primary care in Japan and to show you what kind of care we are providing. Okay, so first, here are the basic demographics of Japan. The population is approximately 124 million, and more than 50% of people live in urban settings. Japanese is the most dominant ethnicity, but recently ethnic diversity is growing. Japan is known for the longevity, and both sexes still live more than 80 years. From now on, I will be showing the case of women with multimorbid conditions presenting with both acute and chronic issues. At the same time, I will be telling you how I would manage this patient in my own primary care setting if I were the primary care physician seeing her, considering the core functions of primary care of comprehensiveness, continuity, coordination, and access. About comprehensiveness, in Japan, patients are free to access to specialists and visit multiple healthcare institutions. Additionally, there is an abundance of specialist clinics which deal with common health problems. Thus, evaluating the comprehensiveness of primary care is challenging. A primary care physician will provide home visit care, including treatment and monitoring for MAID conditions such as hypertension, diabetes mellitus, COPD, and osteoarthritis. However, may need to visit an ophthalmologist about her vision problem. Continuity of care. The local municipalities in overall Japan provide community-based integrated care. The system conforms the Long-Term Care Insurance Act. In the scheme, care manager play an important role to coordinate medical and welfare service. May will receive home visit from a new doctor. If the patient doctor retired or did not provide home visit, the patient or family may request a new doctor to manage. Coordination of care. May is in urgent need of both medical and nursing care support. It is difficult for her to visit the hospital, so we will provide her home-based medical care and nursing care and long-term care. About medical care, a primary care doctor visit May's home. As a result of medical examination, she was diagnosed that the respiratory tract infection had caused an acute exacerbation of COPD. The treatment was started by antibiotic drop, inhalant, and steroid at home. A blood test will also be taken to check for diabetes mellitus. About nursing care, nurse will plan regular visits for monitoring and early detection. About long-term care level is determined according to the long-term care insurance system. The care manager coordinates the best living support for MAID, such as housekeeping and bathing. Access to care. Japanese universal health system can cover her medical condition with the support of local government. Japan have efficient private and public transportation system prepared even in rural areas. She can be supported by established mutual help in rural context. Strengths of primary health care in Japan. Japan has achieved universal health care coverage. Additionally, Japan has the most CT and MRI scanners per unit population in the world, which enables good accessibility to imaging tests. Although patient data scatter across medical institutions due to the free access system, many patients have a medication record book that prevents duplicate prescription and drug interactions. Because of the super aging society, Japan is establishing a structure called the community-based integrated system that comprehensively ensures the provision of health care, including primary health care and nursing care. In the system, we have professionals called a care manager who coordinate medical and nursing care. What impaired achieving these these core functions of primary health care in Japan. Because of free access to medical institutions, patients use various medical institutions freely without the permission of primary care physicians. All the patients with multimorbidity tend to accept medicine from multiple specialists, causing the issue of fragmentation of care. The poor information sharing system among specialists can harm all the patient care. Although the need for family medicine has increased, medical university education tends to focus on organ-specific education. Lessons for other countries. We have a scheme to provide integrative care, including both medical and welfare service for every individual. A care manager is a key person to coordinate care. Although patients do not have their own medical record by themselves, many patients have a medication record book, and healthcare providers can recognize their medication by the notebook. Thank you all for your attention today. In closing, I hope that you understand the Japanese healthcare system now. Thank you very much.
Thank you very much, Naoko. That is very, very informative and a lot of new lessons for us that we can learn from you. I would like now to move, travel you all to Thailand and introduce Dr. Raviporn to present how she is going to take care of May, if May is a patient in Thailand.
Good afternoon from Thailand, ladies and gentlemen. My name is Dr. Raviporn Charan Sawat. I am a family physician at Nan Hospital in the north of Thailand. It's an honor to share the experience of a family physician in Thailand with you all today. Oops. First of all, I will give you an overview of the demographic of Thailand. The current population is 66 million. The number of elderly is growing and now ranked the third most rapidly aging population in the world, having the number standing at around 12 million, accounting for 20% of the total population. Like many other countries, Thailand is experience growing urbanization with around 51% of the population living in urban areas. There are approximately 70 ethnic groups. Around 94% are Buddhist and roughly 5% are Muslim. Thailand's unemployment rate is 1.2%. The life expectancy of Thai population is 77.7 years, with female live longer, up to 81 years old, while male's life expectancy is roughly 75 years. As you all know, my presentation will be about how May will be taken care of if she lives in Thailand. I will start with comprehensiveness of care. From a family practitioner's view, there are two main parts of the problem list. The first part is the diagnosis of the disease, which include type 2 diabetes, hypertension, COPD, and osteoarthritis of the hip. And in this visit, she presented with shortness of breath and an acute persistent cough, which could be pneumonia and need treatment for acute infection. The other main part is the illness experience. She is an elderly female living apart from her son, suffering from dyspnea, pain in the feet, and blurred vision. As a family physician, I would like to point out how important of patient-centered care and that we need to have more time for complete comprehensive evaluation. So in this case, we will schedule a home visit or send her an invitation letter for long-term care. And at the bottom of the slide, we can see the ABCD EFLMNOP mnemonic diagram for May's comprehensive evaluation to evaluate all the common problems that may arise in geriatric patients. In terms of continuity of care in Thailand, it's unlikely that May is seeing a certain doctor in public primary health care practice for 10 years. As there are shortness and high turnover rate of staff, it's more likely that May has been receiving care from the same nurses at primary care unit that close to her, or as a retired bank officer. If she is well off, she might be seeing a private primary care physician paying out of pocket and having continuity of care for more than 10 years. But not the case for majority. In Thailand, community-based healthcare has a significant role in maintaining the continuity of care for a complex case like this, particularly where a district health system is well functioning. The multidisciplinary team ensures comprehensive care for patients like me. This team comprises health professionals from public hospitals, including family physicians, pharmacists, rehabilitative professionals, and social workers. Working together with staff at primary care unit, mainly primary care nurses and public health professionals. And in our system, village health volunteers ensure community engagement and have a core function in maintaining the continuity of care, particularly in the rural areas. However, this model is not always the case for the care of patients in urban areas where the system is fragmented. Although having more resources, including in the private sector, but most private practice have not been engaged with the service under universal health care. In terms of data continuity, we pilot a digital data network in the northern region to improve the continuity of health record data. So every medical professional under the district health system involved to care for May can have access to her medical record. This system also has the data shared between primary, secondary, and tertiary care. Now, moving to the issue of the coordination of care. Family physicians, primary care physicians, and primary care nurses have central role in care coordination. In the pink box, we can see how the care is coordinated from hospital-based services to community-based services. In the community, patients and their families receive service at home through a multidisciplinary team. In the case of May, this team will provide home care in which the service package includes blood pressure, blood sugar monitoring, evaluation her foot pain, and health education services. And they will also link May to the other available health promotion programs in the community. As her vision is getting worse or the foot pain needs further evaluation, she will need a referral to see a specialist. At the secondary or tertiary care hospital, which will be coordinated by primary care team. In terms of access to care, Healthcare services delivery under the public sector are fully covered by universal health coverage since the implement of healthcare reform and the establishment of the National Health Security Office around 20 years ago. May is likely to be one of 72% of the population whose care is covered by the Universal Health Coverage Scheme. In getting access to care, she can go to the health center and see a primary care nurse or call a village health volunteer in the community. The village health volunteer will then inform the nurses at the healthcare center. The nurses at primary care units work closely with community hospital staff. These hospitals provide training, supervision, and share resources with primary care units to strengthen primary care services capacity. If patient needs service that are not available at the community hospital, he or she will be referred to tertiary care hospital at the provincial or regional levels. The principal goal of primary healthcare is to ensure equitable distribution of healthcare in terms of both horizontal and vertical equity. Thailand's universal healthcare has ensured horizontal equity as all people with the same health need will equally receive the same care that they need. Meanwhile, the primary healthcare system managed to increase vertical equity by improving access to care for those who have more health needs. So, universal health coverage together with primary healthcare increase financial accessibility and improves health equity. Family physicians and primary care teams improve the equality of services through a patient-centered approach with the function of district health systems. Lastly, the community-based primary care model coordinated primary programs and needed services, making them available to the patients through home care delivery, particularly for those with NCDs and the elderly. Although we know the strength we have, we are not the stage comprehensive services and continuity of care are accessed and coordinated for every patient. So what impedes us from achieving these core functions of primary healthcare in Thailand? The first problem is the scarcity of family physicians and multidisciplinary teams in primary care setting. The proportion of primary care physicians per population is roughly 1 to 30,000 or higher. The second problem is that Thailand primary healthcare model is largely hospital-based, as a healthcare budget are allocated to the hospitals. There is limited negotiation power for primary care services improvement in comparison to competing interests to improvement of hospital, secondary, and tertiary care capacity. The next problem is that there remain limited engagement of available private primary care practice in the primary healthcare and universal healthcare systems. Moreover, there is still lacking collaboration regarding digital health data. And lastly, a significant proportion of migrants and ethnic minorities are not covered under universal health coverage. So what lessons do we have for other countries? Universal health coverage increased health equity and protection against financial catastrophe. Primary healthcare system in Thailand functions through the district health system, enable to coordinating of multidisciplinary team, which make comprehensive services for complex cases like this. universal health coverage and primary healthcare system proved to be the key strength of Thailand's health system during the COVID-19 pandemic. To improve the coverage of primary healthcare, the system needs to be strengthened through engagement and capacity building for existing primary care practices. I hope this will provide you with more information about the function of family physicians and primary healthcare in Thailand. Thank you.
Thank you very much, Dr. Raviporn. We have seen the system of two very different countries. We see some similarities and some difference and many things to learn. And we are now moving to the West, seeing how South Africa is doing and how they will be taking care of May. I would like to invite Professor Bob. The floor is yours now. Raviporn, you may need to stop sharing.
Okay, yes, thank you very much. You can see the slides, all right? Yep, cool.
Yeah,
so, yes, thanks. Yeah, so we're moving to Africa now. So I'm a family physician in Cape Town, South Africa. Let's see if we can get these slides to move. Hang on. 1 second. Let's try doing it like this.
It's good. We are on the demographic.
There we go. We got it. Right. So yeah, South Africa. So about just over 60 million people now, and mostly urbanized in cities like Cape Town. People still, unfortunately, use these ways of describing the population. So 80% are Black African, and about 23% of the population actually is Zulu, and about 16% is Xhosa. Those are the two biggest sort of language population groups. Unemployment is a staggering 33%, and life expectancy has got up to about 65 years in South Africa, which means you don't find many people over the age of 60. Okay, this is the case that we know. That's what I'm imagining May looks like on the Cape Flats. I put access first because you've got to get to care first, hasn't she, before anything else happens. So actually, this is probably the aspect of care, as you can see, only 27% of people in South Africa rate access as good. And I'm speaking about the public sector. I'm not going to speak so much about the private sector, but it's free. So May can access care for free. She lives in a rural area. She may struggle a bit with the roads and the distances. There are also some organizational barriers to access. So there's very high patient numbers, and facilities are not usually open in the evenings or the weekends. There's usually not really functional appointment systems. So people turn up at the facility at like 5 a.m., 6 a.m., and try to be at the front of the queue so that they can be seen that day. And unfortunately, I think communications are still pretty poor. If you try and phone the facility, probably nobody will answer. There's no telehealth services really as an alternative. Many patients, of course, may decide to bypass primary care completely and try and go to the primary hospital, which is common, or in some communities see a traditional health practitioner. And she certainly, all the services she needs are theoretically available, and I'll speak more about that just now. And of course, certain groups, if she was a migrant, for example, she might struggle a little bit more to access care. In terms of comprehensiveness, actually, this was quite highly rated in South Africa by our users. 67% thought this was pretty good. it depends which sort of primary care facility she's going to access as to who she will see. Most consultations in South Africa are with a nurse practitioner. So it's more likely that she'll see a nurse practitioner. If she accesses care at a community health center, she may, especially because of her complexity, she may end up seeing a doctor. In the community, we could actually help her a bit because we do have now extensive community health worker teams throughout the country. And so they could actually follow her up at home, even offer some physical care, support adherence to medication, link her back to care when necessary. So that's a positive. We would be quite good, given her cough, at seeing if she has TB, which of course in South Africa would be thought number one before, although she also has COPD, I see. All of her acute and chronic problems actually would be treated at the primary care level. Medication particularly, I think, is good. There's an essential drug list, and by and large, it's available. So all those conditions that she has could be sort of prescribed for at the primary care level. However, patient education, sort of like the kind of patient education and empowerment that chronic conditions would need, particularly like diabetes, hypertension, and so on, is very limited. It's most likely that her consultation will last about 7 minutes with a nurse practitioner who will re-prescribe her medication and test for TB. But giving her sort of further empowerment is a bit limited in terms of self-management. Rehabilitation, which she might also need some help, is also quite limited. There might be a few therapists in the district, but it's most likely that the community health worker actually would provide her with some limited support at home. In terms of continuity of care, this was also rated quite poorly by our users. 45% only thought it was good. So the medical records are all still pretty much paper-based. There's a reasonable chance that they won't find her folder when she turns up at the facility. And therefore all this like wonderful medical history is not available when she's consulted. If she had HIV, that was a very different story because there's lots of resources for HIV and they've got electronic records and so on. So unfortunately she has diabetes, which means that she might struggle a bit more for informational continuity. I would have to say, really, I don't think there's any serious commitment to relational continuity in our system. She's probably going to see a different nurse or a different doctor if she's lucky every time. But of course, if she's in a rural area or a very small clinic, there's so few staff that she probably will end up seeing the same people every time. Or some programs, as I've mentioned, such as HIV and mental health, they might have more dedicated staff that she'll see. Coordination of care actually also rated fairly well. 68% thought this was pretty good in South Africa. In terms of sequential coordination, primary care is meant to be the gatekeeper. So actually you can't just rock up at the regional or central hospital and expect to see a specialist. You have to go through primary care. There is some ability to bypass primary care to the primary hospital, which is also usually a generalist space, so that you're not going to find medical specialists there. But that often is common. People will turn up there in the emergency center. Obviously, to refer, and that's what is true for many people, to refer to a specialist, if she needs to see that ophthalmologist, she might wait an awfully long time before she actually gets to see that person. And what we found is also there's very poor communication. So in one study we sent people off to the hospital outpatients, but only got feedback in about 40% of the patients. So in fact, the feedback mostly was the patient trying to tell us what they thought had happened. So, in rural areas, there's also limited emergency. If you need to go as an emergency or you need some sort of help to get to that next level of care, it's quite limited. I know some districts in rural Eastern Cape have only one ambulance that's working. And there has been some attempts, especially I think in the cities, to improve coordination by the use of digital technology and various apps, which actually have worked quite well. There's also, in her case, a need for parallel coordination. And so, for example, she may be, if she had, for example, HIV and diabetes, she might need to coordinate between two different care teams. And in her case, I think very clearly a need to coordinate between the facility-based members of the primary healthcare team and the community-based members. I think in her case, the community health workers could be quite helpful to support her. So, okay, this was like, I can't see the title myself of this slide. It's covered by Zoom. But I think I think this is about the strength, isn't it? So actually, our users are pretty good. They like our cultural competence and the availability of a multidisciplinary team. And as I've mentioned, I think our sort of attempt to implement community-orientated primary care is a strength and has huge potential, which we still haven't fully realized, and includes this quite extensive potential team of people. Family physicians, unfortunately, when I say family physicians, I'm referring to doctors who have had some training in primary care or general practice. They are available and have great potential to assist in a complex patient such as May, but of course are not often that available. And then the differentiated models of care is also of value to her. What that means is that stable people with chronic conditions, their sort of follow-up is largely pushed into the community, so that the facilities can focus more on those who are unstable or have new conditions. So that's helping us quite a bit. Then what impedes achieving these functions? Well, money. I mean, overall in the country, 50% of all the resources that are spent on health are spent in the private sector on only 20% of the population, which means May and the 80% of the rest of the population have to make do with the other 50%. Currently, in where I'm sitting in the Western Cape, our budget is going to be reduced by 1 billion rand a year for the next 3 years, with probably a loss of about 5,000 healthcare workers. So things are not getting better financially. Low capacity at the National Department of Health. So unfortunately, May doesn't have HIV, because there's about 40 people looking after HIV at the National Department. But for diabetes, there's only 2. So there's a bit of a lack of capacity there. And I think, low capability of sort of mid-level managers for really implementing primary healthcare well. As I've said, a reliance on primary care providers with limited training, such as community health workers and nurses, and a failure, essentially, to deploy the available family physicians into the primary healthcare space. Most of them, and even at the primary hospital, it's limited, but most of them are deployed at the primary hospital level. And then I think, as you've seen, need to improve the health information system, especially patient records, and some issues with infrastructure and so on. And certainly digital technology needs to be brought to the fore. So what lessons can we share? I think this concept, especially for a sort of low middle income country, of having a multidisciplinary team that balances coverage and quality. So the team can have coverage through community health workers and nurses and so on, but include, and this is what I think should include, a family physician and others to balance coverage and quality. So, somebody with a slightly higher level training. The community-orientated primary care approach, which in essence focuses on the whole population at risk rather than just the people that walk through the door of the facility, has massive potential. And that, I think, in our setting, could be a game changer if it's fully implemented for some of our big problems like TB and HIV and so on, diabetes. The sort of interdependency of the primary hospital and the primary healthcare platform, that's a key strength if that works well. We have to deploy family physicians. We've got to train them, got to have them, and then we must actually deploy them into the primary healthcare space. And that seems like a nonsense thing to say, doesn't it? But that, we're actually having that conversation with our policymakers, and they're not all convinced. And this problem, it's not going to go away. If anything, it's going to get worse, of huge workload, small numbers of healthcare workers, having very short and inadequate consultations. How do we find alternatives to sort of provide quality, given that that's not really going to change? So we're looking at things like group empowerment, digital technology, differentiated models of care, and I think there are some lessons there. And then finally, I think the one thing that we have been doing is we've been driving an annual audit of norms and standards called the Ideal Clinic process, which I think has improved gradually and incrementally, the quality of care. So that's it. Thank you.
Thank you very much, Professor Bob. That's a lot of information and very inspiring. You have provided us with the information about the evaluation of primary healthcare performance, and that inspires us in Thailand to do the evaluation of the performance as well. So we are coming back to the east, to another country that is close to Thailand. And I would like to invite Professor Tin Mew Han to present the care for May in Myanmar. The floor is yours, Tin, Professor Tin.
Yeah, thank you, Pete, for your inviting me to join this Wonka webinar series. Good afternoon to all my colleagues and ladies and gentlemen. Thanks to giving me opportunity to share my primary healthcare and family medicine experience with all of you. You already know Myanmar is one of the member organizations of the South Asia Pacific WONCA. Our total population is 55 million. We have 8 major ethnic group and 135 minor ethnic group. Most of our population live in the rural area. Life expectancy of our population is 67.36 years, and employment rate, this is officially published, is 2.17. Actually, I think it's more than that, but we are not sure about it. So in this presentation, I will base on like the other 3 countries. 75-year-old Myanmar lady, like named is Mel. She have diabetes, hypertension, COPD, and OA. Now she came to see me for the acute problem, acute chest infection. So you can see this is my clinic situated in my community. So that lady visit to my clinic with one caregiver, because in our Myanmar culture, the most of the retired old lady live with one caregiver, and then most of our Myanmar lady are not familiar with drinking, also barely driving at the age. Comprehensiveness, our Myanmar GP major primary healthcare provider in Myanmar primary healthcare provider, together with the other provider from the government services, charity clinics, INGO and NGO clinics, and OBD or the military hospital. So our GP trying how to provide the comprehensive care, screening all the disease, like the acute and chronic health problem, like the measles. Also, we provide the immunization, especially COVID vaccine immunization to our patient like Mrs. Men and other patient. Also, we treat all ages, ethnic group, and all gender. So we also try to provide the psychosocial support as much as we can to the patient like Mr. Mel. We needed our support. However, we have a limited training and resources, also limited support by the government health authority. Besides, our family medicine are not recognized as special discipline like the other country. Continuity of the care definitely in our Myanmar private GP clinics, because most of our GP clinics are solo clinics. Also, second or third generation healthcare provider practicing in the same clinics to provide the healthcare to the community. Also, we also have a record. So mostly we have a paper record, but Myanmar Academy of the Family Physicians support us to be accurate our record keeping in the electronic system. So that's why we are now practicing to keep the both paper record and electronic records. So some private hospital and private GP also provide the record to the patient to keep by their own. One significant nature in Myanmar is doctor shopping by the patient. So they can be select a doctor whatever they want to take treatment from them. So we also have the traditional medicine and the sex management because of the limited health literacy and limited financial problems. So we Myanmar GP coordinated with the government hospital and private hospital and other NGO clinics, project-based clinics. Before the 1st February 2021, our military group, we mostly refer to the government hospital because this is a free of charge for our patient. After that, we have a limited access to the government because of the CDM movement or the government has that limited services in there. So we had to be referred to the private or maybe charity clinic. In that case, Mrs. Bell had to be referred to the private hospital. So this depends on the patient who are preference, whether they want to go to the government or private or which doctor they can select. This is we call the doctor shopping. So we have a different gatekeeping system in Myanmar. So we also have no proper referral and counter referral system between the government and our private healthcare services. That is why we had to be empower our patient to monitor their blood pressure and then their blood glucose level. Our GP trained our patient to monitor their health status. Also, our GP are also monitor their status when they visit to our clinics. So this is our Myanmar healthcare system. So coordinated care, this is a typical case of the missing male and other diabetes patient. We have a diabetes center in the government hospital, also private hospital, also our primary care clinics in the Yangon. So my clinic also provides the palliative care. That's why some our GP clinics and then specially refer their diabetes patient to take the treatment regarding the palliative problem and diabetes food care in my clinics. So we also provide the home care to the missing meal and other patients. We also have geriatric assessment at the home visits. So we have a coordinated care, but this is a fragmented. Because of our primary care healthcare system are fragmented data in our Myanmar healthcare system. So access to care is limited now because of the economic problem, also recession, also political instability. And most of our private sector are out of pocket money. Patients had to own by themselves for the investigation, medication. So we had to be looking for the donation and charity clinics and other NGO clinics to get the universal health coverage. So our Myanmar is one of the WHO member countries. We also implement universal health coverage, implementing, and then we are going to include private GP in universal health coverage. This is a planning stage. So unfortunately, we changed the political system and then we are now lost their way to include our GP in the universal health coverage. So for the accessibility for the GP clinics, this is a 24 hours, 7 days. But we are now have a curfew time, midnight to 4 a.m. This is very difficult for the patient to get the access during the curfew time. For that, we have the volunteer ambulance team to have that kind of the patient to looking for the health services during the curfew hour. So this is a accessibility of our Myanmar. So remote consultation. This is now very popular in Myanmar because of the COVID-19. and then now limited access to the government services. So now we GP provide the remote consultation by the e-media. So Viber services, also other electronic media, WhatsApp, and then Facebook. So this is an example of the Diabetes Society, also provide the digital management of the diabetes healthcare to our patients. So we have a teleconsultation system in both our private system, also government system. So this is a strength of the primary healthcare in Myanmar. We are fragmented. Universal health cover is very limited, but we are trying our set to provide the quality and comprehensive care to our patient as best as we can. So we have a question for the equitable and universal primary healthcare. We also practitioner have been able to enable the opportunity optimize the care. But we have a success story of the diabetes and hypertension. This is supported by the Professional Association, the Hypertension Society, Diabetes Society, and project, INGO project, collaborated with our Myanmar GP Society to implement the primary health care, diabetes and hypertension. So Mrs. Med are also included in their care system. So they can get their free access for the care, also support for their medicine. But this is now limited because of their support are now limitation because of the economic recession, and then send into a withdrawal from our Myanmar. So this is our situation. That's why we need to do many research to get the evidence what happened in Myanmar to present like other country. So this is our weakness and our strength. So now we are trained by ourselves. This is our CBD program by our professional association, our GP society, also MAFP, and the other now Young GP society conducting CBD program to empower our professional to understand how to provide the continuity and quality care. Also, we had to empower our patient. Also, we had to empower by ourselves to be survive in the difficult situation in Myanmar now. So you can see now, impact of the COVID-19 epidemic and political instability on the healthcare services in Myanmar. So including our primary care health services are affected on the death situation. So this affect both in public hospital, also private hospital, also our family medicine, deployment and private primary care practice. Because most of our community, Mrs. May are retired person, limited pension salary, and then they cannot get a regular treatment, and then they are also trying hard to looking for the support from the charity clinic. Also charity clinics withdraw and limited funding. So we have many problems in now, but we are still surviving to be provide our services as much as we can to provide to keep the core or the function of the primary health care. So that's why you can learn from the Myanmar is a typical country. So effect of the epidemic and political instability, effect on the family medicine deployment, also quality and safety in primary care. Also political commitment, support of the government authority, very important. We Myanmar GP society, GP practitioner, we have limited support. So that's why we have many constraint to move forward, development of the family medicines. Also, healthcare system, we have a limited health insurance system. Also, like a retired person, we have no insurance system. That's why the old and pension person, like very difficult to live in the Myanmar to get a quality care, continuity of the care by the patient. So this is a negative point of the view of our Myanmar primary care and family medicine development. But we have a positive energies. This is a volunteer spirit. we had to be encourage each other, and then we had to support each other, and then we had to be support professional tourism for our private Myanmar GP development and family medicine developments to be provide the quality and safety care to our patient. We also need the support to conduct the primary healthcare research in Myanmar. So this is a lesson learned from the Myanmar cases. So we had to be conduct the Wonga APR in 2021. We had to move to 2022 because of the COVID-19. It's okay. We are working hard for that. But unexpectedly or fortunately, that's political changes made it very difficult to conduct. So now just finished the Wonga APR 2022 in Bali. We also thank to our Indonesian colleagues within short notice they carry out our Wonga APR conference. So thank you so much to all. So we want to invite you all if we have the opportunity to conduct our Wonga APR conference in Yangon. So thank you so much. Thank you.
Thank you very much, Professor Tin, for a motivating presentation. I think we are all in the same boat towards the path to improve the health of the population through primary health care. And I would like to invite Professor Chris Van Wiel for his comments. Chris, you need to open your mic. Chris, the microphone is not yet opened. Okay.
Yeah, it's open. Yes. Sorry. Thank you very much, Abby, and presenters. Thank you very much for a fascinating view of the way primary care operates in your country. I think this is a monumental event in which on a Monday we're discussing with an audience of over 60 people primary care around the world. And compliments first to the organizers of getting this off the ground. This is never done before, so this is unique. And I think it highlights a huge development in primary care. I would like to start with that. I understand that all the presentations will trigger lots of interesting questions that should be covered. What I would like to do is give a couple of general comments in the context in which we are doing this. And my first comment is that what we've seen is that we have been able to discuss the care for a very complex patient in a terminology that we all understand, with reference to values that we all share. And I would dare to say 10, 15 years ago, this would not have been possible. And this is a huge progress in primary care that we, whatever the problems we're facing, and there are many, whatever the challenges we have to overcome, and they are substantial, this is something that we have been able to do, and that is progress. That is very, very important. You've been able to articulate, and in it, we all come to the same understanding of what needs to be done. Again, that is substantial progress from not that very long ago. And we do that on a global scale. Fantastic. At the same time, of course, the discussion of the cases highlights the challenges and the difficulties we're facing with. One other point I think came forward, and that is, and again, 10, 15 years ago, we might not have been there. Primary care is part of the health system, yes, but primary care is also part of the community. And that is the place where we are. That's the place we share. That's the place we have to develop our strategies to improve the care for people and for populations. Public transport may be just as important for access to care as the availability of laboratories. Well, I think that is a common ground. What the 4 presentations also illustrate so fantastically is, yes, we have common values. We see the common pathway to improve primary care, but the way to do that, we have to operate in a very diverse world. Different countries, within countries, huge differences between the city and the remote areas. So the strategies, the way to solve the problems depend very much on the local situation. So it is common values, common challenges, but local solutions. And there are, I think there are 2. One is the internal primary care. Are we really moving from an individual provider, a family doctor, to an integrated team? Is the access to care of this patient simply ending because the doctor retired because of retirement age, or is there a logical continuity within primary care? A very important thing that we're struggling with everywhere around the world. And the other is, it's not just primary care, it's the hospitals, it's the universities, it's the health systems, health policy, it's community. We call that stakeholders. They all have a stake in the pie of the provision of healthcare. But for the way we're able to develop in the local situation, it's not just the understanding of their stakeholderness. It's probably also important to understand, are they allies? Are they the most important group to turn to in solving our problems? Or are they absolutely not interested in primary care? We cannot make progress without support from others. And the first support we probably will get from people who are with us in understanding the need of primary care. And maybe this is the university. In some countries it is. In other countries it may be the hospital. Patients. I'm coming from the Netherlands. In the Netherlands, we know that with all the difficulties we had in accessing allies on the path to primary care, patients and the community have been our most truthful allies in that process. And we have to make strategic choices, and each has to make that in their own situation of where we find the allies and what will be the best way under the given circumstances to move forward. 4 marvelous examples. The world is larger than that. I think we stand together in doing it, and we have to work under the local situations. And I think from that perspective, I would like to invite you to continue the discussions, and I will rest my case here. Thank you very much.
Thank you very much, Professor Chris. Always inspiring as it is. And I saw some question. I think I saw a question from Sukma that he would like each presenter to describe how the patient will receive the care for their emergency needs and how that will be subsidized or covered. May I start with Naoko first?
just repeat the question again. What was it?
Okay. Okay.
Thank you.
Okay. Now, if you would like me to repeat the question again, Sukma asks, from his perspective, he thinks the family, as a family physician, we have to prepare the referral system first due to her tend to emergency clinical condition. After that, family and social support should be provided by us as a care manager. But to establish this system, we need the financial support. So he would like to ask and learn from the 4 presenters on how to make the referral successful from primary care setting, especially if it is a private clinic. You can correct if I am, yeah.
Okay, so, and would you please repeat the question again? Is the private clinic or a public clinic?
It could be a private clinic, yeah. But
Okay,
if you are sitting in a private clinic and you have a patient coming to you with a need that needs maybe in emergency condition taken care because she's an elderly, may have respiratory tract infection that needs further evaluation.
Okay, so even in the public clinic or a private clinic, we almost do the same things. And if the patient needs the home-based medical care, some of private clinic provides the home visiting, or public clinic also provides the home-based medical care. And the system, the government recommends this system because our society, a lot of super aged people, and they cannot come to hospital, and they have to stay at home. So the doctors have to visit their house to provide the medical care.
And if they need to go to the hospital, can they go to the hospital? Who will pay the cost of the hospital?
Yes. If they prefer going to hospital, yes, and their family will send them to the hospital. But in Japanese society, most of the aged people is a husband and wife, both are over 90, very, very old, and they cannot go to the hospital anymore. So that's the case. We provide the home-based medical care.
Okay, so in case like if you evaluate and he or she needs antibiotic, you will provide the antibiotic right away, and you have the IV fluid or to maintain the hydration at home, right?
Yes, that's right. But at home, we can provide the antibiotics drop like on the self-tory action. It just once a day. But if the antibiotics, we have to provide 3 times a day, it's impossible. So the antibiotics is very, very limited. And we can provide home-based medical care in a limited way. And if the patient want more treatment, we send them to the hospital.
So
yes.
Is my understanding correct? Most of Japanese population are covered by any types of insurance. They are covered by government insurance. So the healthcare is covered, right? They don't need to pay out of pocket.
Yes, but how is the patient condition? It's up to the patient condition. They cannot move at all, or the patient needs all of support to spend a daily life. They can get a lot of support, but if the patient can go shopping or can do something by themselves, we ask them to go to hospital by themselves. Yes, okay. So the home-based medical care is just for the patient who cannot go to the hospital and they don't have any tool to reach the medicine. This is the system.
Okay, thank you very much. So I will move to Raviporn to the same question that Dr. Sukma asked. If she needs emergency assessments and needs hospital care, how could she get the care she needs at the hospital? Is her cost of the care covered?
First of all, as I said in the slide, I said that most of the patient covered by the universal health coverage, about 70% of all. So so this means she can go to the community hospital, or she can call the emergency number on her cell phone, like 1669, and then our ambulance from the community hospital will pick her up, and the costs are free for emergency or acute disease.
Okay. So just to elaborate,
but in the I said about public sector, but in the private sector, she might have paid by herself first, and then maybe she got transferred to the community hospital or the provincial hospital or the excellence center. It's up to her severity.
Thank you very much. Just to elaborate, so in Thailand, population are covered by universal health care. So the care that they need are fully covered. So in this case, if she receives the care at a private clinic, the doctor at a private clinic will refer her to a public hospital. So she can get the treatment, emergency needs, that emergency care that she needs. On if she needs hospitalization, she will be hospitalized without a need to pay from her pocket. And then after the hospital care, the primary care team that works with the hospital will refer her back to her community. In her case, it's likely that she will have the help of a village health volunteer to help informing the primary care team at the primary care unit and coordinate the referral for her to the community hospital. Now I invite Bob for the same question that Sukma asked.
Okay, thank you. So if she needs emergency care. So as I said already, in the primary care space, there's actually 3 different types of facilities. So in the urban setting, the clinic actually, the nurse there might refer her initially to the community health center, which often is open 24 hours a day at that level and has an emergency center itself with doctors. So she might then get assessed there and treated potentially. Obviously, if she needs to then be admitted to a hospital, they would then refer her to what we call the district hospital, or others call primary hospital, which is still a generalist space. So typically your primary hospital just has sort of male, female wards, labor ward, children's ward. It's not a specialist space, and she could be referred there to their EC and could be admitted for further investigation or treatment, and that would be the most likely scenario. All of that is free. The patient, doesn't have to pay for that care. They might, if they're sensible, organize their own transport, because they might wait a very long while for an ambulance, especially if it's not a sort of life-threatening emergency. So, then if that district or primary hospital needs to refer upwards, that then gets, I think, a bit more tricky to get in at the central or tertiary level. And certainly part of our position in South Africa is that we want all of those primary hospitals to have a family physician, so that there's somebody, you know, with training in family medicine available at that level. And that varies a lot between provinces. So the expertise available at that primary hospital may also vary considerably. But that's essentially how it would work.
Thank you very much, Professor Bob. And we move to Professor Tin from Myanmar with the same question that Dr. Sukma has asked. Tin, you are mute. Open, yeah.
Yeah. Thank you for question. So any question from the audience? Can you hear me?
The question, yes, Tin. The question from Dr. Sukma is, as the patient is coming with possibility of emergency need for the acute care, if he needs treatment in a hospital, how does it work in your country? Who will be covering the cost of her care at the hospital, and how it functions if you are practicing in a private practice?
Yes, emergency care. We also have emergency cases in our primary care clinics. So at that time, we had to manage a case by case. We haven't have a protocol for the emergency case. Depend on the case, severity, depend on the severity, and it depend on the patient background and patient preference. So patients are very poor and affordable to cover by their healthcare costs. So we encourage to go to the government hospital, and then we are looking for the donator who will be donate for the healthcare cost for that patient. We also have the negotiator. We had to be ask someone. We had the emergency case. They had to be admitted to the hospital, government hospital. Previously, we refer to government hospital. Sometimes government hospital cannot cover the emergency cases. At that time, we had to refer to the private hospital. The private hospital also have a screen for the poor patients. So we had to negotiate as the advisor of the patient. We had to negotiate with the private hospital to get the discount rate or affordable price for our patients. So this is what happened in Myanmar. So usually we refer to the government hospital free of charge. So at the time and the same function are limited in government hospital. So we had no choice to go to the government private hospital. So for the private hospital, we had to be negotiate with the private hospital to cover to discounts the cost sharing for that's emergency case. So small emergency cases, we had to be treated by ourselves. And then we had to take the responsibility for the patient. Let's say yesterday we had one head injury cases. There's no serious cases, we had to monitor by ourselves. That's kind. So this is an emergency case. We had to go to the hospital. We had to negotiate with the hospital, both government and private hospital. Thank you.
Thank you very much, Professor Tin. That's very clear answer. We see the clear function of a family physician, that you are doing everything your best to have your patient being treated. If the public hospital has the function, you refer to the public one, the government one. If not, you find many means, right? Finding funding and negotiating the price, making sure that your patients are safe in the hospital that has higher capacity. Thank you very much. I would like to ask Professor Felicity if you have any comments, anything to add, or if anybody has additional question. We still have 5 more minutes for the webinar.
Thank you, Bea. I think Chris covered the the features of this webinar very well and very clearly. But if anyone got any questions they want to ask, and you're welcome to open your videos as well. It's nice to see people. So in the last few minutes, if you'd like to share your videos, that'd be fine. I can't see the whole screen, but has anyone got any questions? No, I can't see anyone with a hand up.
Okay, there is no coming questions, but I see Sukma just add that it's relief that there is a privilege for elderly in 4 countries that they have their family physician to be providing care for them. Okay. So Professor Felicity simply invite the audience to open the video. Simply we can see each other and support each other. As Professor Chris say, we are on the same boat at the different stage of development, and we learn from each other, support each other, and find alliance on the road. Feel free to open your mind and share your thoughts. Professor Klaus, do you have anything to add? Dr. Klaus von Presentin. It seems you're moving, but you haven't opened your microphone.
Sorry, are you talking to me? No, I've got nothing to add.
There is a question in the chat. Someone asked, what is the recommended ratio of family physicians to population? There's a thorny question.
It's a question from Dr. Ping Fu Wong from Malaysia. Anybody would like to answer this question? Maybe we can ask Professor Chris, Professor Felicity first, from the country that has more experience. What is the recommended proportion?
So in New Zealand, we'd like to have about, for full-time GP, 1,500 patients per GP. It's a sort of number to that you can manage without being too overloaded. The reality is that it's often more than that, but I don't know. I mean, other countries, I suspect, will have much higher numbers. But Chris, be interesting to hear what in the Netherlands.
Professor Felicity, let me just make try to clarify. It's 1,500.
Yes, 1,500 patients on your book for per GP. It's sort of ballpark. Maybe 2,000.
Professor Chris?
Yes, I think it's roughly the same idea. The Netherlands, for a very long time, we had a ratio of 2,500 per full-time family physician. We think that is a bit too much given the aging population. The increase of part-time family doctors, which needs more time to hand over and to share care. So we would come to 1,500, 2,000, but that is an ideal because it is far from the reality. And the alternative, of course, is strengthening the primary care team like they do in South Africa. And it both have its pros and cons. I think we need a stronger primary care integrated teams. We need a doable number of patients per capita, but it's very difficult to mention a number because that will then serve as if it's the number is the fix, and I think the quality is the fix.
Thank you very much. Professor Mehmet, you raise your hand.
Yes, I just want to add to this actually the same approach like Chris said. I mean, maybe the real question is now not the proportion of the family physician, but the proportion of the population to a team and how to define this team, because it's quite, I mean, dependent on the tasks that you give to one person and how you share these tasks among the bigger team. So there is a long, I mean, discussion on this. Maybe we will never find the real best number for it, but the world is also quite changing to a more team-based approach. So maybe the question also needs to be changed a little bit. On the other hand, when I get the microphone, I just want to say one reflection on all these presentations. The common point in most of the presentations, especially very predominant on the three, was community. So either community-based healthcare, community integrated care, or directly community-oriented primary care. Also, I think this is nice to discuss on this. All these settings were quite different, and maybe it is good to start the exercise. I mean, what do we mean actually when we say we are more community-oriented approach? And this will also go to the third theme of our webinar series, especially in the COVID-19 times. So this was more predominant question. I mean, I know that our time is very limited, but I will be very much interested to explore actually in all these settings, what do actually, I mean, from your point of view, from the presenters, what they mean with community orientation in reality in their countries. Thank you very much.
Thank you. Before we go to the answers from the presenter, I saw Bob raise your hand. You have anything to add?
I was going to, but is our time up, or is there still time?
Yeah, I think we give it up to it's 5:33. We will try it by 45, not longer than that.
All right.
So 10 more minutes roughly.
So I was going to comment on that question on the family physician ratio to population. So this is actually, on the one hand, an impossible question to answer, because it depends on what you mean by family physician. You know, whether you're referring to people with postgraduate training in family medicine or just a doctor. Also, it depends on the model of care that your health system has. So on the other hand, policymakers want to know how many family physicians do we need in our country. And so it's kind of like a question that you kind of have to answer in your context. You know, in high-income countries, typically, as has been said, you have about 7+ family physicians per 10,000 population. In like countries like China, it's 1.2. In Brazil, comes down to 0.2. In South Africa, it's 0.16, including the private sector. In the public sector, it's 0.05 family physicians per 10,000 population. So, but you know, to say, well, what should it be is very difficult. So what we've said pragmatically in South Africa to our government is every primary hospital should have a family physician, every community health center should have a family physician, and every sub-district which doesn't have a community health center should have a family physician as a 10-year goal. That's not the end, but so maybe one has to be pragmatic about it in your context.
Thank you very much, Professor Bob. So we come back to the question that Professor Mehmet asked, and I think there is another question that is more or less this, in line with the question that Professor Mehmet asked. What is the level of training of community health workers and range of skills in the country? So I will combine the two questions to the speakers. The first one, what do you really mean by community-based primary care, and what level of training you provide the community workers? So the first one, I think I will change the the order a bit, starting with maybe Professor Tin.
Thanks for your remarks.
Anything you want me to answer?
Yeah. So what do you in your country, do you apply community-based
Yes.
primary health care? And what does it
Yes.
mean by that? And what level of training you provide to community workers?
Community worker, there's two sessions. One is from the government sector. And this is a government community health worker. This is an appointees. And another one is a community health worker. This is a volunteer. This is for the privates. So for the private sector, government also training, also our professional association, and then INGO and NGO project also train the volunteer. Our Myanmar GP Society also train the volunteer who are working for the community health project. For the government community health worker, government trained. They has a training school in the Magui Township. For us, we have a community, and each and every township, they are organized by the professional Myanmar GP Society or any other volunteer society. They contact to us or maybe other training based or national-based non-governmental organization. Also, sometimes government also support that training. Mostly community health training, community volunteer health worker trained by our professional and international and national INGO project. This is sponsored by the international funding. Like the UNICEF, WHO, HIV/AIDS, malaria, hypertension, also the psychosocial support training and empowerment of the women, reproductive health. We have many projects. Yeah.
Thank you very much, Professor Tin. And then I move to Naoko. What do you mean by community-based primary health care?
Okay, and to community-based primary health care, in our country, the government has established a community support center in each area, and it almost depends on the popularity or on the school district scale. So in the city, we have some of community center, and it covers about the elementary school size houses for each community center. So, and in each area, we have care manager or some people to take care of the patient. Does it make sense? This is my answer.
Thank you very much, Naoko. And Dr. Raviporn, what is your response to community-based primary health care?
Of course, in primary care unit, we have strong connection about collaboration to do community-based hospital and community hospital. We made ourselves as a position as a primary healthcare to consult and to referral if the patient needs special treatment or special diagnosis, or if we have no resources. And how about we like the question is to like
I will help explain in this question. Community-based health primary health care, in this sense, we work a lot with people in the community who are not health professionals. At primary care unit, we have public health professionals, and they provide training to people in community to provide support to each other, to do health promotion program, and they train village health volunteer to provide care for patients that need more attention. So this is how what we mean by community-based primary care, because we have limited number of staff. The primary care unit, which comprises with nurses and public health professionals, they train the community to take care of themselves, to improve their health literacy, and to provide care to each other.
Oh,
And they work collaboratively with staff from the hospital. Okay, now we move to Professor Bob.
Yeah, thanks. So community-oriented primary care. I mean, I think in my mind, the fundamental shift in thinking is from regarding your practice population as the focus of your work to regarding the population at risk as the focus of your work. So what that means is you don't just pay attention to the people that walk through the door of your clinic as the people that you're concerned about. You think about the whole population at risk that your primary healthcare facility is responsible for. And that means you've got to then, first of all, of course, define who that community is. And in our context, it usually then means having both facility-based and community-based services who have to work together as one sort of functional team. And in Africa, that usually means community health workers in the community, but also other people to support them, such as nurses, that in the CHW team is also led by a nurse, and to have not just an individual approach to sort of helping individual people or even families, but to be thinking about the needs of the health needs, the social and sort of environmental determinants of health in that community and how you might address them. So yeah, I could go on for quite a while. I posted an article on it that we've actually defined for the Metro Health Services in Cape Town, where we are trying to implement COPC. I put that in the chat.
Thank you very much. So that is it for this evening. We are now at the end of the first webinar. Please feel free to give your comments. How should we improve? What you would like to learn more? We have 6 more coming, and I leave the floor for Chris to close and Felicity to close, and then we are good to go. And Professor Mehmet too. The floor is yours.
You want me to kick off? I think I'm looking back to a magnificent experience that I thought we would never be able to do on a Monday morning for me, afternoon for you, evening for those in Australia and New Zealand, discussing the core values of primary care in such an eloquent way and with such marvelous presenters and such a lovely audience. So thank you very much for organizing it. Thank you very much for presenting, and I'm looking forward to more in this.
ขอบคุณค่ะ So anybody, Felicity and Mehmet, or we are good to go? Felicity, please.
So I just want to thank you, Abby, and Mehmet, particularly for the idea of doing this and for the amazing amount of organisation you've done to bring it to pass. I think it's a great format. It's fascinating to hear the stories, and I'm looking forward to the next 5. So thank you very much, and lovely to see everybody, and good night from me.
Professor Mehmet.
Well, I would like to thank you all the participants, because I mean, I was just checking the participation number. It hit to 65 according to my control. So that is really a serious number, and with the time zone differences and etc. And when we realized this, I again recognize that it is quite valuable to go on like this. So I mean, it gave me a full motivation to go forward for the other webinars. So thank you very much, all the presenters, and also all the audience who listened and participated today.
Have a good day. สวัสดีค่ะ
Bye.